We're ready whenever you are.
Okay, can we start now?
Yes, sure.
Okay, Bismillah Rahman Rahim. Assalamu alaikum wa rahmatullah. So today we'll be discussing the clinical applications of ultrasound. The gallbladder is an organ which is very easily can be seen by the, actually all the organs can be seen, but ultrasound pathology diagnosis is done easily by ultrasound rather than by other modalities. So gallbladder, you can see it has a cystic duct, and then it joins the common hepatic duct, which forms together a common bile duct. So it can have stones, it can have cholecystitis. Stone can be in the CBD, which will cause biliary dilatation, and we will see a couple of pathological images in the subsequent slides. So it's a pear-shaped structure you can see. And if you remember the terminology, which is important even from exam point of view, that this is an anechoic structure. So there are no echoes inside. It's fluid. Urinary bladder, gallbladder, blood vessels, they are all anechoic. So this is the sagittal section of a gallbladder, and this is the transverse section. You know that transverse are axial. If you cut like this here, so you will have just a rounded structure. So you see that the wall is thin. It should not be more than 3 millimeter thickness. 1 to 3 millimeter, these are normal, and more than 3 millimeter is abnormal. Of course, if it is 5, 6 millimeter, then definitely it is pathological. Sometimes due to ascites, due to hypoproteinemia, and due to cirrhosis, the gallbladder wall is thickened, but that is not because of cholecystitis. So these are the only exceptions. Otherwise, thickened gallbladder is pathological. So in cirrhosis, in ascites, the gallbladder wall may be thickened. Also in heart failure, because there is back pressure and there is congestion. So the image is anechoic, but what is behind that, yani inferior to that? It is bright. So this bright image is not acoustic shadow. It is bright, so it is called posterior enhancement. You know that this is anterior, this is right, this is left, and this is posterior. So when you see a bright thing below an image, that is posterior enhancement. You can see a lot of enhancement here because you are in side section, and this is because all the echoes are passing. You know that fluid is a good medium for ultrasound, so it passes all the uh, echoes are passing, and therefore you have a bright image posterior to it, behind it. And this is called posterior enhancement. Very important to know. What is acoustic shadow? Acoustic shadow is the opposite. That is, the rays, the ultrasounds are not passing through, and so behind that there will be a dark shadow, as the name shadow says. So this is called acoustic shadow. Okay, that was posterior enhancement. The opposite, the dark one, is acoustic shadow. And this is a stone, hyperechoic area. It may be more than one stones combined together in the gallbladder, but the gallbladder wall is not thickened, so there is no complication. It is an uncomplicated gallstone. So if I ask you, what is this? You will say a stone in the gallbladder, but uncomplicated. What is the complication? Cholecystitis. It is not causing acute cholecystitic or chronic cholecystitis. And there is no sludge in the gallbladder also. This is another patient having one stone, you can see, and acoustic shadow behind that. And the bladder wall is not thickened. So this is an uncomplicated gallbladder stone. Now, in this case, not only there is more than one stones, you can see a stone here with posterior shadow, a stone here with some shadow, and there is a dirty echogenic material. This is sludge. This is called sludge, thickened uh, bile with the other cellular debris. And so this is called sludge. This is all sludge. But how is the bladder wall? You see, in the previous one, if you go back, you see the wall. How is this wall? And now look at this wall. So it is very thickened, and hypoechoic is edema. So there is edematous thick wall. You can see this hypoechoic line. Edema is what? Edema is fluid. So fluid will look darker. So there is, this patient is having acute cholecystitis. The gallbladder wall is thickened, edematous, multi-layered, with some pericholecystic fluid and sludge and gallbladder stones. So this is a patient diagnosed as acute cholecystitis with gallstones. Now, you may have in the gallstone structure which is hyperechoic, looking like stone. And remember one thing else in the stone, that if you are in doubt, you move the patient to the left decubitus, right decubitus. Even you can make him stand to see if it moves. If it is moving, then definitely this is a stone. So not only the posterior acoustic shadow is also important, but also the movement. Now this patient is having something, a rounded structure which is attached to the wall. The patient was moved left to right and right to left multiple times. Probably he was asked to sit down also, and this is not moving. One thing. Second thing, there is no acoustic shadow behind. So this is a gallbladder polyp. Okay. So polyp, if it is less than 5 millimeter, don't worry. Just follow it up after 6 months, after 1 year. But if it is more than 10 millimeter, then what happens that it can get malignancy. It can transform into cancer. So better to surgically remove it. So the most sensitive ultrasound finding in acute cholecystitis is the presence of gallbladder stone, cholecystite, with sonographic Murphy sign, that when you, the technologist is saying that when he was doing the exam and when he was at the gallbladder, the patient had pain, especially when he was pressing. So Murphy sign is positive, and there is gallbladder stone, and the gallbladder wall is thickened, as I told you, more than 3 millimeter. And the bladder wall, the gallbladder wall is edematous. There can be pericholecystic fluid. It is not important to have it, but the gallbladder was thickened, hyperemic on Doppler study, and edematous. This is important, especially if the Murphy sign is also positive. This is acute cholecystitis. Gallbladder is distended. There may be sludge. Now you see this patient, the stone is in the neck, it is not shown, but the gallbladder is very thickened, and this is another case of acute cholecystitis. And the patient had CT scan also, and probably this patient was acalculous cholecystitis. Yes, I remember now. This patient is not having stone, but the gallbladder wall is thickened, it is a little bit distended. And on CT, when they were doing it, it was much more distended. So this is acalculous cholecystitis, okay? Acalculous acute cholecystitis. The previous one was calculous cholecystitis. You should know various structures in ultrasound. This is liver, this hyperechoic line, it is the diaphragm, and this is sagittal. So in sagittal, this is up and this is down, or cephalic and caudal. In transverse In transverse cases, which I'm not showing in this slide, we've seen the next one maybe, the anterior, posterior, right, and left in the transverse or axial sections. These both are sagittal sections. So up and down. Here is the spleen. Again, the diaphragm, up and down. So above the spleen is the lung. There is pleural effusion. Anechoic, you see, there is pleural effusion on the right side above the liver also. And the part of the collapsed lung can be seen as echogenic structure. So just zoom the image for the same patient. You can see fluid, anechoic. This is echogenic. So it is liver, hyperechoic diaphragm, and part of the collapsed lung. Another case, as I told you, that sometimes the gallbladder wall is thickened, but it's not pathological because of ascites. So it is slightly thickened, but because of ascites. Again, this is liver, and this is axial section. So this is anterior, posterior, right, and left. And you know that the gallbladder is at the medial aspect of the liver. Yeah, it's the same patient, little bit lower to this one. So you have kidney, right kidney, liver, and then you have fluid, but some debris are there as echogenic material is there. So we call it debris in the ascites. Okay, so when you saw the kidney, in this case, you see, it is echogenic. It should not be too bright, but it should not be too dark. If it is too dark, means that the liver is hyperechoic. And why the liver is hyperechoic? Diffusely because of fatty infiltration. So this is a fatty liver, okay? Hyperechoic liver, when the kidneys are looks very dark, then this is because of the steatosis, hepatic steatosis or fatty liver. Okay, this is again liver, and this is axial section. You can see the diaphragm. Okay, this all is liver, and these are blood vessels with echogenic walls, which is normal. Portal veins are more echogenic than the hepatic veins. But these two structures, these are nodules. So these are two lesions. Well-defined hyperechoic lesion in the liver is hemangioma. Okay, so this is how hemangioma will look like. Hyperechoic nodule in the liver, and this is called hemangioma. This is a large nodule or a mass lesion in the liver, but it is almost isoechoic to the liver. Part of it is slightly hyperechoic, but again, if you compare with this one, so at this area it is isoechoic, but well-defined lesion. On the right aspect here, it is ill-defined. This is metastasis, proven metastasis from colon cancer. Okay, so a lesion which is isoechoic or hypoechoic, it is worrisome. Although 30% of the hypoechoic small nodules are hemangiomas, but majority of hemangiomas are hyperechoic. And whenever you see a hypoechoic nodule, we must do CT scan because we don't know whether it is malignant or benign. Liver abscess can look like this, heterogeneous. You see some fluid is there, some echogenic material is there, as you see pus. So pus is not a clean fluid. So the borders are very irregular, shaggy appearance of the borders or the contours. So this is how an abscess will look like, okay? We use ultrasound to also aspirate or take biopsies from the liver lesions are anywhere in the abdomen, rather anywhere in the body, which is accessible. So this is how we do that. We put, this is aseptic technique. You can see the gloves and also the patient is covered. And then we put gel, sterile gel inside, also outside. And with the help of the screen, we insert the needle. You can see here, this is the needle. Okay, this is how it will look like in ultrasound. And this is the abscess. So to drain the abscess, we use ultrasound. To take biopsies also, we make use of ultrasound. So multiple hypoechoic nodular lesions in the liver, until proven otherwise, they are metastasis. Okay. So this is hypoechoic nodule, large nodule, another one, a smaller one here, a larger one here. These are blood vessels, the linear one, these are blood vessels, diaphragm, and little bit of the fluid, pleural effusion. So multiple hepatic metastatic lesions. The borders of the liver, when they are very irregular, you see, and when there is ascites, and especially when it is a bit nodular also. And actually this is nodular, that is why, because the borders are irregular. So this is a cirrhotic liver. So cirrhosis will look like this, irregular contour, shrunken liver. You can see the liver is shrunken. And sometimes you will see portal vein direction, which is away from the liver, centrifugal rather than centripetal flow. So this is a case of cirrhosis. GG in French, this is from a French website, Guba, means lymph nodes. So this is aorta, a transverse section, celiac trunk, splenic artery, hepatic artery, and all these rounded structures are lymph nodes. So the patient is having lymphoma and retroperitoneal lymphadenopathy. Okay. Now look, normal kidney. The dark area, this is the medulla. The brighter area is the cortex, corticomedullary differentiation. It is well preserved, you can see. In the middle is the sinus, where there are cavities, calyces, which will join here to make a pelvis, renal pelvis. They are visible when they are dilated, when there is hydronephrosis, okay? And the kidney, you see that it is not bright. When the cortex has lost its echogenicity, rather it has increased its echogenicity and become almost like sinus, then that is, you can see that it is pathological, and we see it in renal failure. Those patients who are having end-stage renal failure, you will see that they are having very echogenic kidneys and smaller kidneys. Now you see that the cortex is okay, it is not echogenic, but look at the pelvic calyceal system. It is very dilated, and urine, since it is a fluid, it will also look anechoic. As I showed you, gallbladder, it is dark, anechoic. Similarly, here are the pelvic calyceal system. Now look at the normal kidney, as I shown you before, and look at the hydronephrosis, okay? Again, hydronephrosis, but now you can diagnose this structure, hyperechoic, with acoustic shadow. So what is this? This is a stone in the renal pelvis, obstructive stone causing the hydronephrosis. In the previous case, we did not see stone. Stone might be in the ureter. This is another case with a stone. Clearly, you can see in the calyces, lower calyceal group, middle calyceal group, upper calyceal group, forming the renal pelvis. So pelviureteric junction stone causing hydronephrosis. You must know that gallbladder and kidneys are very, very important structures, very easily diagnosed by ultrasound and always asked in the exam. So in this case, you can see that the stone is in the calyceal group at the edge, and so it is not causing hydronephrosis. So this is a non-obstructive stone. Okay, very, very important. Look, hyperechoic image, which posterior acoustic shadow. So this is a non-obstructive renal stone. The patient came with renal colic. Urinary bladder, where the ureter is entering into the urinary bladder, distal ureteric stone, you see. So this is causing ureteric dilatation. You can see here, ureter is dilated. And also if you go up and look at the kidneys, there will be significant hydronephrosis. So what is the diagnosis in this case? Clearly, it is hydronephrosis, okay? There are degrees of hydronephrosis, whether it is mild, so it is subjective, whether it is moderate, whether it is severe. So in severe, you can see that the cortex is compressed and it is relatively thinner. And in mild, the pelvic calyceal system is just visible, visible to slightly dilated. Otherwise, normally you don't see the pelvic calyceal system. This is the upper pole of the kidney, and almost half of the kidney is replaced by a rounded structure, which is anechoic, so means it is fluid. So this is a large renal cyst in the lower pole. Look at the normal kidney. This is the lower pole. This is the upper pole. The upper pole is here, and the lower pole, rather lower half of the kidney, is replaced by a renal cyst. So this is a simple cyst. Inside there are no septations, no nodules. So this we follow up by ultrasound. This is the same case. You see better the kidney. We measure it, it is 9.3 centimeter. I think, yeah, there is another case with a relatively smaller cyst. This is again a small cyst, benign cyst, so no septations, no nodules inside, mural nodules attached. If there's a nodule attached to the cyst, then that is dangerous. You have to do CT scan and biopsy or surgical removal, surgical excision. It may be malignant then. So as you see cyst in the kidneys, you can also see simple cysts, which are called biliary cysts in the liver also. So this is diaphragm, this is the liver, vessels, and there is a large biliary cyst. Okay, so cyst can be seen anywhere. Especially, this is another case. You can see a cyst. Okay, and usually you will see posterior enhancement behind the cyst. An anechoic lesion will almost always give posterior enhancement. Remember this word, posterior enhancement. Posterior enhancement. Here, posterior enhancement. So now this case, as the letter M shows, this is not a cyst. It is not anechoic. It is isoechoic to the cortex, means it is tissue. So this is a tumor and it has to be surgically removed. Compare with the normal kidney. Now, as I told you that corticomedullary diffraction should be there, you don't see much of the medullae, okay? And also the kidney is very bright, almost like the sinus. So this is a renal failure patient. Compare with the normal kidney. And so, as I told you, that the kidney becomes smaller very hyperechoic, especially in the end stage renal disease when they need dialysis or kidney transplant. Probably another case you can see, we don't see medaille at all, very bright kidney. Okay, urinary bladder. Again, anechoic fluid, no debris, no stones, no mass lesions, no tumor. We measure it as in elderly patient when they have prostate enlargement and they want to see how much. So up to 50 ml or less than 50 ml residual can be considered normal, but more than that is abnormal. So this is pre-void and this is post-void. Now you see even post-void is 262 ml. So this patient has a very large prostate. And so this is pathological post-void residual urine and he needs treatment. How the pancreas look like. This is how the pancreas will look like. It is anterior, this is a transverse section, and that's why the aorta will look like this. Artery, the celiac trunk will look like this. And since the splenic vein is longitudinal going to the spleen here, on this side is spleen, so you will look, it will look like a tubular structure. You will see it as a tubular structure. So this is splenic vein, anterior, posterior, right, left. So anterior to the splenic vein, you see a longitudinal structure, echogenic structure. This is pancreas. This is another patient with pancreas with fat infiltration because it is quite bright. This is a case of chronic pancreatitis with multiple calcifications. And you can see on CT scan, calcification look bright. Like you see calcium of the ribs and the bones, they look bright. Similarly, calcium will also look, the stone will also look bright. So multiple calcifications and a bit diminished size of the pancreas. This is how chronic pancreatitis looks like. So fluid in the abdomen, but having debris, it is ascites, dirty ascites. And these are the small bowel loops which are floating in the ascites. The vessels, you can see aorta, but this portion of the aorta is not normal. Dilated focal dilatation of the infrarenal aorta. So therefore, this is an aneurysm. The right iliac artery is also showing a small aneurysm. And similarly will be the appearance in the ultrasound. You can see that a tubular structure, aorta, but in the middle, this is the aneurysmal dilatation of the aorta. So again, here is the abdominal aorta. So celiac trunk and superior mesenteric artery. And this is another case of the aneurysm. But at this moment, the aneurysm is having some echogenic material. So this is partial thrombosis of the aneurysm, okay? This is the carotid artery bifurcation, common carotid, internal carotid, external carotid, and there is a plaque formation, calcification of the atheromatous plaque or calcified atheromatous plaque. The plaque may not be calcified, and those plaques which are not calcified, they are more dangerous because they can migrate to brain and cause infarction. And there is partial thrombosis also, you can see here. This is not aneurysm, okay? This is just the sagittal section of this large plaque rather. This is not thrombosis, sorry. This is the large plaque. This is the axial section of the same one. And so this is a large plaque, atheromatous plaque, which is partially calcified. How the, on the Doppler study, I think we discussed before how it looks like systole, diastole, systole, diastole, systole, diastole. So this is how the artery will look like. And probably I didn't put the vein. The vein will just be showing like the diastole, the whole area will be a straight line, okay? It's not very important, but anyhow, you should know. Anteverted uterus behind the urinary bladder. So this is the sagittal section. So upper portion, lower portion. This is the cervix, this is the fundus of the uterus. The uterine wall are regular. The endometrial cavity, this is the endometrium, the white one, okay? 3 to 5 millimeter is normal, up to 5-6 millimeter even is normal. But it depends on the menstrual period. When it is the secretory phase, it can go even up to 1 to 1.5 centimeter. But in elderly patient, post-menopausal women, if it is even 7-8 millimeter, it is pathological, and you must do biopsy to see if it is not endometrial carcinoma. But in young patients, it depends on which part of the menstrual cycle it is. Now you see here, this is the endometrium, okay? A young patient, normal endometrium, but on the posterior aspect of the wall of the, this is the anterior, this is the posterior aspect, there is an echogenic rounded structure. Here is a smaller one. Usually it is hypoechoic, but sometimes in some of the patient, it can be hyperechoic. But in majority of the cases, they are hypoechoic, and these are fibroids, uterine fibroids, okay? Uterine fibroids can be within the wall, intramural. They can be adjacent to the outer wall, which is called subserosal, like this. And they can be along the endometrial cavity, which are called subserosal, like this one, subserosal. You see, this is the endometrium, and along the endometrial wall is subserosal. When they are large, or especially if they are pedunculated and they are occupying the endometrial cavity, then they can cause secondary infertility. This can be a cause of infertility. Where will the fetus come then? Which place it will occupy? So therefore, it is very important to know that if there is a large intrauterine endometrial cavity, uterine fibroid, it can cause infertility. Very important to know, okay? You see a large subserosal, as you see here. So this one is, you see, hypoechoic, which is in majority of the cases. So this is a subserosal uterine fibroid. Now this cannot cause infertility because it is not occupying the cavity, or it is not compressing the cavity. Now look at this one, a hypoechoic uterine fibroid within the uterine cavity. This is mostly possible that it will cause infertility, secondary infertility. Okay, so I think we are at the end. So usually I ask questions, what is this? But I don't know. I prefer lectures in the classroom because then I can ask. Can anybody say what is this? Is it normal kidney or abnormal? Or what is there? How can I see your answers?
Hello, doctor. You can see the answers by opening up the chat. I think it's the option at the top of the screen.
Yeah, abnormal, hydronephrosis, good, hydronephrosis, dilated pelvis. Yes, dilated pelvis is also correct, but it is not only pelvis dilated. You can see that the upper calyceal group, middle and the lower calyceal group is also dilated. So hydronephrosis is the correct answer. Hydronephrosis, okay? Dilated pelvis is not incorrect, but it is halfly correct. Abnormal, yes, abnormal, you are right, but what abnormal? It is better to say what is the abnormality. So those who have written, doctor, when intrauterine fibroids are surgically removed, can they grow back in the same place? Yes, it can. They can grow in the same place, but not frequently and not quickly. It can happen. The patient is already got pregnancy, and so the answer is yes, but not quickly and not always. Okay, so let's go to, oh, I think there were more messages. 3 more messages. All right, okay. Okay. Okay, so, oh, what did I do? Okay, so let's go to the next. So leave it normal and abnormal. What do you see? Okay, kidney, correct? Kidney is correct. Is there any pathology inside the kidney? If yes, what? Okay. Shadow, yes, shadow, but why shadow? Shadow has a cause. Great. Not only shadow is the cause, you see there is a hyperechoic image, and behind that is shadow. No, you should not say calcification, because calcification can be something else also. Calcification sometimes is not pathological, like some diabetic patients or elderly patients, they have vascular calcifications. No, absolutely not. Somebody said posterior contrast or posterior enhancement. Posterior enhancement is opposite of that. This is dark. Dark is shadow, acoustic shadow. So posterior should be bright. Okay, more. I'm waiting for more answers. Yes, go ahead, guys. Yeah, one more message. Where is the shadow? This is the shadow. This dark tube, dark line. This is the hyperechoic image. And this is the dark shadow behind. I can't really see the kidney. Come on. This is kidney. This is kidney. Do you see my arrow? So this is the kidney. This is the cortex. This is the sinus. And this is the small stone with posterior acoustic shadow. Dilatation of the ureter? No, ureter is not seen. I'm not showing you ureter. This is not ureter. I'm showing you only kidneys, and the pelvic calyceal system is not dilated. So the diagnosis is non-obstructive stone. What is the diagnosis? Non-obstructive stone. Okay. Should we go to the next? Any question about this? Obstructive would be with hard nephrosis, right? Yes, yes. Definitely. If there is no obstruction, there is no hard nephrosis. Welcome. Doctor, can you repeat how we know the landmarks of the kidney? Okay, the upper one is this one. This is the kidney. Calyces, dilated calyces unite here to form the renal pelvis and show you part of the ureter, just part of the ureter. Here, this dark area by a small hyperechoic white line. This is the outer cortex, outer border of the cortex. This whole dark area is cortex. This portion is obscured by the bowel gases or whatever. This portion is not visible, but this portion is visible also. So this is kidney, this is sinus, this is the stone, and this is the shadow. Done? Doctor, in the exam, will we be told what organ is it or what we will have to know just from the image? I think you may be told that this is this, but right now, today's lecture, did you see how liver looked like? Can you differentiate between liver and kidney? I think sure. You will be able to. But maybe there are some questions which say that, if the patient comes and he is having renal colic, so you think I will give you image of the liver? No, I will give you the image of the. Okay, let's go to the next. Okay, what is this? Is it kidney or is it liver? Liver, good. And you say metastasis? Okay. So if I say how you describe these lesions, how you will say? Hypoechoic, not hypo, yes. Hypoechoic nodules, multiple hypoechoic nodules in the liver. Good. Okay, the differential diagnosis which you don't need to, but sometime in patient with cirrhosis, they also may have multiple nodules. But then the liver is very irregular and you have the history. The history is also very important. If the patient comes with CA breast, CA prostate, CA colon, and they say elevated enzymes, what is in the liver, and you see such things, you will not say cirrhosis. Definitely you will say metastasis. Okay, good. So somebody who asked me that there will be image and organ will be told or not. So do you see that I didn't say what is this, and you said liver metastasis. Could these be described as fibroids? Fibroids are the term specific to uterine masses. Yes, fibroid is the term specific to uterine masses. Okay, so let's go to the next. Is it kidney? Is it liver? Is it gallbladder? Is it spleen? What it is? Yes, again liver. Only 3 people are answering. Inshallah. Yes, malignant. This is a malignant lesion. So we don't say cancer, we say malignant because it may be primary, it may be secondary. Good. Multiple now. Yes. So now you know you can differentiate between liver. Isoechoic? No, this is not isoechoic. Iso means like the liver. Now you see this is dark, darker compared to the liver. So this is hypoechoic. Okay, I will give you. The spleen also looks like liver, but the spleen is smaller, and also it will be in the left hypochondrium. We can say that on the left side of the patient, we saw this and this. But I will show you. I think in the lecture there was a case, but anyhow, no problem. I'll show you. Okay, so let's go to the next. So describe, what do you see? No, somebody says hyperechoic areas. You know, the blood vessels and these structures, their walls are also hyperechoic, but that is not the main thing. Somebody said something which is correct, but I'm not going to say because then otherwise. Yeah, this is correct what you are saying, but I want to know what is this? What is this? Ascites, correct. And these contours, how they look like? You think they are regular like this? You see this contour? So yes, rough irregular contours, correct. So, and this, the liver is smallish, no? It's quite small, huh? So shrunken liver with irregular contour, with ascites. So this is, until proven otherwise, it is cirrhosis with ascites. Great. Okay. So let's go to the next. Yes, go ahead. Describe the lesion and then give the diagnosis. And do you think there can be any problem with this patient? Especially if she's young and okay, good. The answers are all correct. One question is it intrauterine? Look, this is uterus. This is uterus where I am showing the arrow. This is the uterus, and anterior to it is the urinary bladder, which is anechoic. And this is the lesion, the nodule, which is shown by measurement. So is it inside the uterus or not? I can't see the cavity. You cannot see the cavity because the cavity is occupied by the mass lesion, and so I am showing you only the fibroid and not the whole cavity. You need more images to see the more the cavity, but you can see that the wall of the uterus, like this is the wall, so it is within the wall, but also it is occupying part of the deep uterine cavity. Okay. Okay, so I'm not finished, but I think, yeah. So we can see also the fetal parts right from the beginning, first the gestational sac, then the embryo, then the cardiac beat, and then we follow it up, okay? And then you can see the 4 cardiac chambers, the ventricle, auricle, or atrium, and then you can see the spine, you can see the abdomen, you can see the urinary bladder, you can even see the diaphragm. You see, this is the diaphragm, this is the chest area, the cardiac chambers, and below the diaphragm is the abdomen, in which you can see the liver and the gallbladder, the stomach, and here is the urinary bladder. And this is the part of the spine. We do 3D images. You can see now, this guy is a bit philosopher thinking, and this baby is crying, okay? So although this case is saying you bye, but I'm still here, and I'm going to show you the spleen as somebody asked. So let's go to the I had an image of the spleen. Yeah, you see here, this is the spleen. So look at the size. It is like the kidney tray, if you have seen in the hospitals, small kidney tray. Yeah, you might not have gone because you are still in second year. So it's like a kidney tray, like a bean. And look at the liver, quite larger, and you can see the diaphragm. Okay, so structure wise, echogenicity wise, it is almost the same. Okay, now the other thing is that you must know when you prepare the patient for the CT scan, and if he is having allergy, then how you prepare it, you must know this thing. And you are using the gloves and the apron for shielding, so you must know what is the minimum thickness. Otherwise, you take a paper thin shield and you think that it will be enough. No, this will not be enough. So you must know all these things to protect your patients and to save patients from having shock from contrast reaction. And similarly, the terminology, you must be knowing that how anechoic looks like, how hyperechoic, what is anechoic, all these things, okay? Doctor, could you explain slide 43, slide 12? Okay, 43 and 12. Doctor can ask a question. Yes, why not? Anybody can ask any question. So I'm going to show first 12 and 43. Okay, so let us see. So this is 12. Yeah. So 12, this is liver. This is hyperechoic line. This is the diaphragm. Dark anechoic thing will be fluid, so it is pleural effusion. And small echogenic area, which is part of the collapsed lung, So again, the spleen just now we saw. So spleen, and this is the hyperechoic line, which is the diaphragm. Below the diaphragm is the spleen, okay? And above the diaphragm is again dark anechoic area, which is pleural effusion. So let's go to slide number 43. Okay, 43. So this is a sagittal section. Okay, so sagittal section, I told you that this space will be cephalic and this will be caudal. Okay, so up and down. So you are coming in the abdominal aorta. And so the vessels, it gives branches. This is the aorta again. So this all is aorta. And the first branch definitely is the celiac trunk. And the second branch is the just next to it, a few millimeters below. This is above, this is below. So this is the SMA, superior mesenteric artery. Okay. This patient is having an aneurysm. Okay. But so you can see echogenic material inside. So this is partially thrombosed aneurysm. Okay. So let us go to chat. I am a little bit confused. How can we identify the liver on ultrasound? Okay. Now you can see that this is gallbladder, and adjacent to that echogenic area, this is the liver. See, this is all liver with having blood vessels. Those blood vessels which walls are not bright, they are hepatic veins. If the walls are bright, echogenic, then they are portal veins. So this is liver, and this is gallbladder. And remember acute cholecystitis, thickened. This is very important. Okay. So see the liver. This is how liver will look like. But if you have half of the image, then sure you will not be able to say whether it is spleen or liver. But if you have the whole image, then definitely spleen looks like this, kidney tray shape, and the liver will quite big, large area. So what is the next question? Okay. So anything else? So you must know all what I said. I gave you big hints, very useful hints. And if you have any other question, you can ask. Otherwise, we are done. Welcome,
Good morning.
all of you.
Doctor, good morning.
Morning, yes.
Doctor, could you go over slide 41 just one more time, please?
Slide which one?
41.
41. Okay, no problem.
Thank you.
Yes, so this is fluid, but it is, you see, it's not anechoic. It is having echogenic material inside. So these may be cellular debris. The patient might have a little bit of hemorrhage, maybe. We don't know the reason why it is. So you have to tape it and see. Sometimes it is bloody, sometimes there are cellular material within it, okay? So this is ascites, but not clean ascites. And these are, if I show you a cine image, these are floating, these are moving, these are the small bowel loops in the abdomen, in the peritoneum cavity. So, okay. Did you follow? Okay. Any other question? You will be able to differentiate between mass lesion and cyst of the kidney. Okay, so if no question, then I leave. Mass is isoechoic almost. Yes, it can be hypoechoic, it can be hyperechoic, because angiomyolipoma, they are hyperechoic. I didn't show you because you don't need to know much of these. So this is just the basic things. Hyperechoic, if the image which was like hemangioma, if you have hemangioma type image in the kidney, that is angiomyolipoma. Angiomyolipoma. I will not give in the exam because I didn't show you, but since you asked, so tumor will look isoechoic. Yes, isoechoic, hyperechoic, or slightly hypoechoic, but not anechoic. Anechoic is fluid. Anechoic is cyst. Okay, any question? Yes, cyst is anechoic. Yeah, the one who says iso or hypo, yes, but hyper also. It can be hyper, like the hemangioma in the liver that you saw. Let me show you. Let me show you. Yes, you see, if this nodule, you take it and put it in the cortex of the kidney, this I will report as a hyperechoic nodule is seen in the renal cortex corresponding to angiomyolipoma. Angiomyolipoma, okay? It's a benign tumor. Follow? Okay, welcome. Cyst is anechoic. Yes, cyst is anechoic. Yes, this is hemangioma. Okay. Any other question? Okay, great. If no question, then I'm going to leave, okay? I'm still here 1-2 minutes. If anybody wants anything, I'm not leaving until you guys leave.